Bismillahirrahmanirrahim. Hi everyone. So in this video we are going to talk about chest pain that is likely to be acute coronary syndrome, and we'll talk about historic points and tools that are usually used to risk stratify these patients. So let's get into it. Of course, as you know, some patients are more likely to develop acute coronary syndrome or coronary artery disease than others, and these are just some of the traditional risk factors that most of you are aware of. There are other risk factors that are a little bit non-traditional, so to speak, and these are the ones we probably need to pay attention to. And this can still enhance the probability of patient having acute coronary syndrome when they're presenting with chest pain. So keep those in mind as well. Coronary artery disease in women, I think, is worth mentioning. There are certain features that are kind of relatively unique to women compared to men. So for example, women are less likely to have typical symptoms. The odd ratio of that is about 0.63 compared to men. And they are more likely to have angina equivalents, which are the non-chest pain symptoms that still could be related to acute coronary syndrome or CAD, like shortness of breath, dyspnea, palpitations, and presyncope. And they're also more likely to have like atypical symptoms like indigestion, for example. Women also have a delayed presentation and delayed time to treatment after symptom onset, and they have more hemodynamic instability and cardiogenic shock, so a little bit more likely to be sicker. Older age at diagnosis, which is about 10 years more compared to men, and subsequently women have more comorbid conditions by the time they are diagnosed with CAD. There is higher prevalence of non-obstructive CAD in women compared to men. Spontaneous coronary artery dissection affects women in more than 90% of cases and is the leading cause of MI in women younger than 50 years old, which is about 24 to 35% of acute coronary syndrome in this group, which is kind of interesting. Also, they have poorer prognosis than men after MI. Results of non-invasive diagnostic testing have lower specificity in women compared to men as well. So for example, the ECG treadmill exercise testing in women has a false positive rate of 38 to 67% compared with 7% to 44% in women, much higher. Women with STEMI treated with fibrinolytic agents are 2 to 3 times more likely to experience hemorrhagic stroke than men. But after PCI, women and men actually have shown to have like similar short and long-term survival. So so this is really important because I believe as a hospitalist, when I see a patient coming in with acute coronary syndrome and they're women, or they coming in with like non-specific chest pain, I have a little bit lower threshold to kind of suspect CAD in them. Not that they need like more unnecessary testing, but it's just really something to keep in mind. A quick note here about the blood supply to the heart. So there are two forms of circulation, the macrocirculation and the microcirculation. And the macrocirculation, basically these are the larger epicardial arteries. These are the arteries that are seen during the coronary angiogram. Wider diameter, the diameter goes down, as the artery goes to form the small arteries and arterioles and then capillaries. And the main function of this is, of course, transportation of the blood to reach the myocardium. And any pathology here is structural, like atherosclerosis and stenosis. These can be seen during the angiogram. So any fixed lesions in this macrocirculation can lead to flow limitation, especially during increased demand, like during exercise or stress. And then the rest is the microcirculation. And again, the diameter goes down and down as the artery penetrates the heart structure. And then there is the arteriole level which precedes the capillaries. And there, the metabolites are really kind of the main stimuli for the diameter changes or the vasomotor changes. And of course, as the diameter goes down, the resistance will go up. And in these arterioles, any dysfunction will still lead to angina. We call it like microvascular angina. And these are the patients who might have anginal symptoms, anginal chest pain, but their angiogram is normal. So they still don't have like the big, large atherosclerotic disease or narrowing or stenosis, but they still have microvascular ischemia. And some people call this cardiac syndrome X. And of course, still diabetes and hypertension can be contributing to that. These small arterioles could be the reason behind a condition called MINOCA, MI with non-obstructive coronary arteries. And there are different possibilities of that, which include coronary vasospasm. You might see this spontaneously without any particular trigger, but more commonly is associated with the use of medications or some illicit drugs like cocaine or methamphetamine and other medications. It can often occur at night, can happen at rest, but it also can occur after exercise or exertion. ECG may mimic STEMI. It's a diagnosis of seclusion, so most of these patients will end up needing coronary angiogram. You might consider, or the interventional cardiologist might consider invasive provocative testing, but this is not mandatory for diagnosis. And treatment is empirically with nitrate and or calcium channel blockers to prevent, hopefully, the spasm, but of course, addressing the underlying cause. Spontaneous coronary artery dissection, younger women in the peripartum period are more commonly affected. It's due to development of a non-traumatic and non-iatrogenic intramural hematoma with or without intimal dissection with lumen communication. The enlarging hematoma in the false lumen will compress the true lumen of the coronary artery and leading to ischemia. Diagnosis obviously requires a high index of suspicion, and confirmation by invasive or non-invasive angiogram usually required. Also rare and less common if you have like a coronary embolism, a clot coming from somewhere, blocking the way of the small arterioles, for example, atrial fibrillation, infantile myocarditis, or thrombophilic conditions. But again, these are not common. Sometimes just due to microdysfunction or CMD. Some people call this cardiac syndrome X, again, more common in women. We talked about that. Anginal chest pain in the presence of angiographically normal coronary arteries or insignificant coronary artery disease, less than 50%. Stenosis, this is more common. One theory is coronary microvascular dysfunction, as I said, and treatment is beta blockers, calcium channel blockers, nitrate, and other anti-anginal medications. Now, sometimes other diseases can mimic MINOCA, like more commonly stress cardiomyopathy or myocarditis, but these are not typically due to dysfunction or blockage in the smaller arterioles. Completing the picture about risk factors, this is just a table that's showing the pretest probability of obstructive coronary artery disease and its relationship to gender and the type of symptoms. So as you can tell, increasing age is associated with more risk of CAD, including especially in men, and especially if the presentation is chest pain, especially if it's typical chest pain. Angina equivalent has less probability of being associated with coronary artery disease, but the possibility is still there. And obviously, if the patient already had coronary artery calcium scoring testing, the higher the previous or current calcium scoring testing, the more probability that they have CAD when they present with chest pain or angina equivalent. Now let's talk about symptoms. Acute coronary syndrome obviously presents with chest pain, but importantly, physicians should know that obviously sometimes the pain is not really necessarily exactly in the chest, right? Some patients may actually present with shoulder pain, arm pain, neck pain, back pain, upper abdominal pain, or jaw pain. Sometimes this could be just radiation, but sometimes the main discomfort or pain could be in these areas. So that's important to note. And then many patients actually might not say pain. In fact, if you ask them if they have chest pain, they might say, no, I don't have chest pain. But if you ask them, okay, do you have any discomfort? They say, yeah, there's a little bit of a pressure or discomfort, right? So they can use really different words, and that's really important to note. Something like pressure, tightness, squeezing sensation, heaviness sensation, or burning sensation. So this is very variable. Again, we talked about angina equivalent. Sometimes patients might not mention any of these, pain or pain equivalent. So they might say something about, they having like shortness of breath, nausea, fatigue, faintiness, very vague symptoms. Also could be still acute coronary syndrome or angina or coronary artery disease. And this is usually more common in women, more common in elderly. Patient with longest-standing diabetes or longest-standing hypertension more likely to develop atypically, as we mentioned before. An important factor to note when you're taking the history, obviously the patient has a language barrier or like neurological or psychiatric disorder, or cannot provide accurate history, or they are what some people like to call poor historian. This patient might be more challenging, and you might need to be more careful with them. So when a patient comes to me with acute chest pain, I would like to think of what makes this chest pain not really ACS? What makes it less likely to be acute coronary syndrome? For me personally, at least, I feel like this is more helpful. So for example, if the pain is really sharp, fleeting, just very few second duration and then it disappeared, it's very unlikely to be ACS. Pleuritic nature, I think that's really important. So if the chest pain is worse with inspiration or with coughing, I think of something else other than ACS usually. Positional also decreases the probability of the chest pain being ACS. Localized below the umbilicus or above the mandible, like if it's too far from the precordium, also less likely to be ACS. Radiation to the trapezius ridge, which is the upper border of the trapezius muscle below the neck. This is more typical of pericarditis or musculoskeletal cause. For pericarditis, it's probably because of the association with phrenic nerves. The phrenic nerve supplies the pericardium. And with pericarditis, this pain, pericarditis pain, can be felt in the trapezius muscle, especially the trapezius ridge, which is the upper border of it. Radiation to the back between the shoulder plates, think of aortic dissection, but also more likely to be musculoskeletal in nature, less likely to be acute coronary syndrome. Now, of course, all this is just estimate. Right? We still can see patients with atypical presentation, but really it's very helpful to move them up and down based on this points that I just discussed. This is true mostly for the group that we talked about, and patients with longest standing diabetes and hypertension and so forth. So this diagram really illustrates this, right? So the description of pain in this side is the one that we just talked about, being sharp, fleeting, very brief, shifting, positional, pleuritic. All this really makes the probability of chest pain being ischemic is less likely. Same for right-sided tearing, ribbing, and burning, although less so compared to these features. This in comparison to the typical features of chest pain that usually suggest ischemia or ACS or cardiac origin. The chest being central, left-sided, dull, aching, pressure-like, squeezing sensation or feeling, gripping, heaviness, tightness, exertional or stress-related, relief with nitroglycerin or rest, retrosternal, and builds over a few minutes, not very quick onset. One thing to mention about relief with nitroglycerin, this is not necessarily diagnostic of myocardial ischemia and should not be used as the sole diagnostic criterion. Now, of course, many patients will fall in between. They might not fit the typical features in this side or the non-cardiac features in this side. So of note, we used to classify chest pain into typical, atypical, and non-cardiac. That's okay, but now they're suggesting for physicians to consider labeling the typical chest pain as cardiac, the atypical as probably cardiac, and the non-cardiac still remains non-cardiac. And this is because they really want physicians to think about the possibility of ischemia even in patients with atypical description of their chest pain. That's why they labeled it as probably cardiac. So these are the ones in between. You're not really sure. It's atypical presentation or atypical chest pain description. You can label them as probably cardiac. Maybe that will make you think of assessing them further to see if they have ACS or not. This is just another diagram that visually shows the probability or likelihood ratio of the patient having acute MI based on the description of the chest pain we talked about. So, for example, the probability is highest when there's radiation to the right arm or shoulder, or radiation to both right arm and shoulder and left arm and shoulder, or if it's associated with exertion or radiation to the left arm alone. Compared to the chest pain is pleuritic or positional or sharp, or there is local tenderness on palpation. These features have less likelihood ratio to suggest that this chest pain is pleuritic. Now, again, this is not 100%, but it's just a suggestion to give you a clue when you're doing the workup for these patients. A quick note here about relieving and exacerbating factors. So we talked about some of the common exacerbating factors, which is exertion, like exercise, hurrying, or sexual activity. Emotions can bring ischemia as well, like during stress, anger, fright, or frustration. Unfamiliar task, heavy meal, or exposure to cold. All this could be triggers. And then it's usually relieved by rest or taking nitrate if the patient had nitrate, or during ED visit or in the ambulance. But as you probably know, ischemia can still occur at rest and while the patient is recumbent. This is called angina decubitus. and this usually happens at night. Some people call it nocturnal angina. So the patient might be awakened at night by typical chest discomfort and shortness of breath. So pathophysiologically, this could be due to different things. Part of that could be because of episodic tachycardia and transient hypoxia during the change in the respiratory pattern that happened during sleep. Also, the expansion of the intrathoracic blood volume that usually happens in recumbency, especially at night, and that could lead to increase in the cardiac size, increase in the end diastolic volume, increase in the wall tension, and myocardial oxygen demand, and all this can lead to ischemia and transient left ventricular failure. So now, after taking careful history and doing a proper physical examination, which by the way is most of the time would be normal in patient presenting just with ischemic chest pain. Sometimes people talk about the ischemic S4 forced heart sound or the ischemic mitral regurg dysfunction murmur, systolic murmur, but honestly this is very rare. I don't know if anyone really can be able to quite often detect that. But anyways, most of the time physical examination is, especially cardiac examination, is not very remarkable in many of these patients. So after history and exams, there's suspicion for ACS. Of course, immediately guidelines recommend getting ECG, ideally within 10 minutes of presentation, and then obtain the cardiac troponin or cardiac biomarker, whatever is available to you in your hospital. So based on that, the priority, of course, and the EMS, this is what they do, is to look into the ECG and see if there's any features to suggest a STEMI, ST elevation myocardial infarction. And this patient will go right away to angiogram. But if there is no features of a STEMI, then the recommendation is to obviously to check a serial ECGs and a serial cardiac biomarkers to try to figure out does it look like it's coming from the heart or something else. So based on that, based on the risk factors, symptoms, history, ECG, troponin, then you use clinical decision pathways to try to sort out is ACS likely or not. And if there is suspicion for ACS, if the patient is low risk or intermediate risk or high risk, or if you can make the diagnosis of non-ST elevation, myocardial infarction or acute coronary syndrome, and based on that you go with the management and other risk stratifications as we'll talk about in the next slides. So what is exactly acute coronary syndrome? The ACC AHA 2025 guideline defined as conditions typically caused by the disruption, rupture or erosion of unstable coronary artery atherosclerotic plaque with associated partial or complete coronary artery thrombosis and or microemboli, resulting in diminished blood flow to the myocardium and subsequently myocardial ischemia. So basically, the way I see it, it's an acute event that happened to the coronary arteries on a background of a chronic event. The chronic event is the building of atherosclerotic plaque over months and years because of the risk factors, certain risk factors that we talked about. What is the acute event? The acute event is either partial or complete or temporally of a coronary artery. Why that event happened? Because of a thrombosis and or of a microemboli. What's the result of that event? It resulted in myocardial ischemia. So based on that, there are three related clinical conditions along this continuum of severity of ACS. So if that event is transient and it resulted in no significant necrosis or myocardial injury reflected by the normal troponin, cardiac biomarkers, this is called unstable angina. And if the occlusion or that event is partial and it resulted in myocardial injury, usually subendocardial injury or ischemia, this is called non-ST elevation myocardial infarction. And if this event was complete occlusion of the artery and resulted in genuine myocardial injury and infarction, usually transmurally, this is called ST elevation myocardial infarction. So these are the three categories of acute coronary syndrome. This is just a diagram to illustrate what we just talked about. So again, acute coronary syndrome, if there is a complete occlusion of the coronary artery on the background of atherosclerotic plaque, this is called ST elevation myocardial infarction because it's usually defined by certain criteria in the ECG that resulted in ST elevation in certain leads. We'll talk about that when we discuss the ECG in future videos. And then the other category is when the ECG does not show ST elevation, then in that case there's either myocardial injury or no myocardial injury. And there is myocardial injury is called non-ST elevation myocardial infarction. And if the biomarkers are negative and there is no myocardial injury, then this is called unstable angina. And they have certain changes in the ECG as well that, again, we're going to talk about when we talk about the ECG in the next videos. For me as hospitalist evaluating patient coming in or being admitted for acute chest pain, this diagram I think is very helpful for me to figure out first if this acute chest pain looks like it's most likely cardiac in origin. Of course, after like what we talked about before, thinking about the serious events, most emergent causes of acute chest pain first, and then looking for the common causes of acute chest pain, and then thinking whether they have acute coronary syndrome or not. So this diagram is very useful. So if a patient who have acute chest pain, but we're really not sure if this is really cardiac or non-cardiac in origin, this is where the Heart score can be very useful. So the Heart score is meant to tell you the risk factors this patient with acute chest pain has, to label them as likely to have an acute cardiac event, stroke, or any other acute atherosclerotic event in the next 30 days, because these are the patients that I want to manage and not miss. So it's based on age, based on the pain description, whether it's suspicious or non-suspicious for ischemia, risk factors for ischemia, 7 of those are included, and then the initial EKG, and then the initial troponin, and then the next troponin ideally done within 3 hours of the initial one if the initial one is negative. So it's to 10. If the patient has 0 up to 3 points, these are low-risk patients. It's most likely that this, or suggests that this chest pain is unlikely to be cardiac in origin, and they have the least risk for developing acute cardiac event in the next 30 days. But if they have like moderate risk, like 4 to 6, then okay, there's possibility that they might have ACS, so maybe I should consider doing stress testing or coronary CT angiography based on what is available for you in your work setting to see if this is really look like cardiac pain or not. And then obviously if they have 7 or more, these are the patients that most likely have ACS, and then I can move to the next scoring system, the TIM score or the GRACE score. So the goal of these scores is really this is again based on the fact that you already suspecting ACS, or it's already diagnosing ACS based on the history and the ECG and the antitroponin. And then you want to know, okay, what to do with this ACS. Should I just manage it medically, or they need to go to left heart cath or angiography, coronary angiography? And if they need to go, do they need to go right away? Do they need to go within 2 hours? Do they need to go within the next 24 hours, or I can wait a day or two, obviously after a cardiology consultation. So based on these scores, if they have like scores like a GRACE score of less than 1.9 or a TIM score of 0 to 1, this patient can be managed medically. Or in some cases, if you're still suspecting some event that might happen because the presentation is not typical, you can consider stress testing. In my case, where I work, is usually the nuclear stress test to stratify these patients further. If they have a GRACE score of more than 40 or a TIM score of 2 or more, these are high-risk patients, and they probably need to go into coronary angiogram for further evaluation and consideration of stenting or further management or CABG, bypass surgery if they need that. So, for example, the hospitalist, if I see one of these features, I know that this patient might need urgent PCI, and I speak with the cardiologist right away. These are patients who have suspicion for type 1 non-STEMI. If they are like hemodynamically unstable, I don't like the vital signs, or they have refractory chest pain, they have ongoing ischemia, they don't look well, they're in pain, not responding to nitrate or morphine, and they have features of left ventricular dysfunction or heart failure, acute heart failure, or they have like arrhythmia that also kind of not being managed by medication. This patient, the highest risk patient, highest risk non-STEMI patient, and they need to call the cardiologist right away to make sure that they, get the treatment that they deserve. So again, I think this diagram is very helpful. This is how I approach my patient with acute chest pain, depending on whether initially the ACS is on the table or not. If it's not on the table, there's possibility of other differential diagnosis. I do the Heart score to see how likely they are to have ACS, and if ACS is already number 1 differential or top on the differential based on their presentation, then I stratify them with a TIM score or GRACE score, and then I take it from there. This is just another diagram to illustrate what we just talked about in terms of the acute management of patient admitted with the ACS. Again, after the basic management, which we're not going to talk about, it's not the scope of the video. Really, as a hospitalist, I want to risk stratify these patients, right? So if, like we mentioned, the highest risk factors for this patient that justify coronary angiogram within 2 hours, including patient with hemodynamic instability, ongoing chest pain, arrhythmias, and all that. So these are the highest risk patient. And then there is patient who might need angiogram within 24 hours, and other lower risk patient who might need the intervention within 2 to 3 days or prior to discharge, not necessarily right now. And then some patients who have like low intermediate risk, obviously this patient needs kind of reevaluation to see if their condition changes, if the condition of the patient changes or not. And then based on that, you decide whether they need stress testing, if they're stable, to again risk stratify them, whether they need intervention before discharge or not. So again, this is just general approach. For me, it's very useful as a hospitalist to have that in mind when I'm managing these patients to see when I need to call the cardiologist early or not. The last point I want to talk about is whether you should go with coronary CT angiography or stress testing to risk stratify patients who are like borderline ACS. You don't really know. First, you really don't know if this chest pain is cardiac or non-cardiac region. This is where you use the heart score. Or you're suspecting ACS, you want to know if they're like high-risk patients or low-risk patients. Again, it depends on many factors, so I will leave that for you to read and interpret. But generally, obviously, a major factor to determine which one to choose is which one is available for you in your facility. And that's the one that you will go with. So there's some pros and cons for each one of these. For example, if you're really looking into non-obstructive coronary artery disease, maybe you should do the CCTA because it visualizes the plaque better than compared to the stress testing of which doesn't really visualize the plaque for you. And CCTA may be better for younger patients for that reason, but for elderly, maybe the functional stress test is better. So again, pros and cons for each one of these two, but whatever is available for you to risk stratify patient with acute chest pain or patient with suspicion or diagnosis of ACS. These are the factors to look at, but availability probably the most important one.